So we move on with our second presentation. Looking forward to see Thomas Modine here on the stage on the Lux Valve experience, 30-day outcomes of Lux Valve plus transjugular tricuspid valve replacement system in the Trinity trial.
Good morning, everybody. I lost my voice because of Stefan.
Oh, so sorry for that.
Any charges should go to them. So I'm a consultant for GenScare, but also I am the co-PI of the study with this gentleman here. So the Lux Valve Plus is a very innovative design. It's coming from China that has been validated by labels from FDA also. So the videos, while I'm explaining to you how it works, shows how it could be implanted. One of the features of this valve, it doesn't rely on a radial force anchoring. It just have two rabbit ears, what we call very nicely rabbit ears, that have to sit below the anterior and the posterior leaflets, and then you have a septal anchor that accomplish the fixation of the valve at the level of the septum. It has a self-adaptative brim at the level of the right atrium that makes the design very interesting in terms of sizing, and we know that sizing is a big issue. And it has a very adjustable and deflectable catheter that is used that could allow, and it allows, transjugular access, and I think this is the valve with which we have had the biggest experience for transjugular access. So the Trinity trial is a pivotal trial that has been conducted mainly in Europe. It included also a couple of centers in China. I will show you this, and the endpoints are primary safety endpoint. And we were looking at major adverse events at 1 month. We will be looking at 6 months, 1 year, and 5 years also, as it's usually performed in that this kind of studies. And the primary performance endpoint was to achieve less than 2+ tricuspid regurgitation without clinically significant paravalvular leak. So I'm co-chairing this session, and as I've said, it included centers from mainly in Europe, France, Germany, and Spain, and of course 2 centers in China and 1 in Denmark with Ole de Backer. So this is the patient's baseline, and I've separated the roll-in patients, 12, which was not mandatory for all centers. So centers who would have felt comfortable doing roll-in patients did the roll-in patients, and some others wanted to go straight forward because they have bigger experience with TTVR. So there is nothing particular here. As you can see, elderly patients, high risk, high STS score, and reduced NYHA and KCCQ. So as I've said, one of the particularities of the valve design is that it has this self-adaptative brim that allows for bigger valves, which is, you can see it, the consequence of this is that 75 of the patients we enrolled had a valve size of 55 and above, and it goes up to 70. And I think today there is no other device that could tackle this kind of anatomy and late referred patients to be treated, except the Evoque with the 56 now. The internal diameter of the stent is 30, which is very important in terms of valve-in-valve positioning if you have any generation, and you know that it could degenerate in the future. So these are the major adverse events that we have seen, and I think we've been looking very carefully to, of course, any failure. We've been looking very carefully to the pacemaker rate, and you can see it in the roll-in and in the patients enrolled really for the study. It was of 8%. The severe bleeding also, if you want to compare it to other available devices, was also very low. And actually, these patients who had the bleeding, we used the MVARG definition. We're still at this stage. 2 of them had gastrointestinal bleedings, and 2 of them had tamponade, which we considered to be severe bleeding. And the major access vascular complications we didn't have. We didn't have to do for surgery for any of these patients, and the access is transcatheter. These are the clinical outcomes. So these results are all analyzed by a core lab, which is Erwan Donal in Rennes. And you can see how effective is this device, but like any other TTVR, the ability to eliminate regurgitation is very important. You can see it here. And the patient who had massive regurg, it was a valve that migrated and the patient has been operated on. Otherwise, and you can see that the real patients, 140, because nine patients are missing. The elimination of tricuspid regurg is very effective and real. What's striking with with TTVR is once you eliminate the tricuspid regurg, patient feels better. The NYHA improvement is although it's only 1 month after the procedure, is real. And it started having a tendency to be also reflected on the KCCQ scores and the 6-minute walking test. I mean, of course, it's too early for these late-stage patients to really express or show any major improvements, but we can see here that there's a tendency to feel much better, which is good. So, in conclusion, I would like to say that this Lux Valve Plus transcatheter tricuspid valve replacement is an innovative, but I mean, this valve has been implanted now in more than 500 patients worldwide. And in patients who are at high risk for surgery, showed based on this radial force independent anchoring mechanism and low demand for imaging quality. Julian has been talking about the importance of having easy to follow, easy to learn imaging process, because that would lead to adoption or wider adoption. The transjugular access showed to enlarge the access to this therapy also, because this angle between the inferior vena cava and the tricuspid annulus didn't show to be a big problem. At 1 month, and then we showed that we had a good safety and performances of this device, with already an improvement of quality of life. And the wide application of large anatomy patients provide very encouraging treatment options for a great majority of patients that we are seeing today in our daily practice. Of course, there are other data which are coming. We just terminated the early feasibility study, are about to finish it very soon in US, and then we are preparing a randomized control trial in US also, in some centers in Europe. Thank you.
Marco.
Thank you very much.
Be gentle, Marco.
I must say that I was not aware of these devices before. I come from the Heart Failure Association Congress, which I organized, so I'm rather exhausted and with some difficulties in adapting my behavior. But I'm impressed by the presentation. There are a few things, and it's an evaluation somehow from the outside. But so first, the size of the study group is quite large, more than 150 patients. You presented only the 30-days data, but you have likely a longer follow-up. But so very large study group. The second thing, the thing I was impressed from the title is the transjugular implantation. And then, however, there is the low complication rate that seems to me lower compared to the data that we have with other devices. And so I'm impressed about this result. You think it has to do with the delivery, the implantation system, and...
Yeah, I think the jugular access itself, once you secure the vascular puncture, it showed to be very effective in terms, you don't have to push and pull on this device. We adapted the technique also during the experience. We don't use a wire anymore. We had these 2 tamponades, so you don't need a wire anymore. You just go in the right atrium reflex, and then the short distance between the jugular access and the annulus itself showed to be, how do you say, they reduce the need of any manipulation of the catheter, so it's very stable, very safe, and very effective. And also, I think being able to visualize only 2 features of the implants, of the steps for implantation themselves, make things much, much easier and controllable. I think it's a multitude of elements that lead to the effectiveness of this device.
Why hasn't it been used or assessed with other devices because of the design of the device? I think,
yeah, exactly. And I think for the FDA is asking for a head-to-head comparison with the gold standard today, which is the Evoke. So this is the study they're going to do. They have to.
The other observation is that you end up with 2 minus or equal to 2 level degree of TR severity. And so it seems to me, on the other hand, a little bit less than the results that have been obtained with the other devices. Nevertheless, quality of life improved more or less to the same degree with the other devices. So my question is, do we really need 0 of TR, or maybe the patient may feel better, have a low complication rate? Because the other thing is also that the pacemaker implantation is relatively low. It's about 15% of the patients. So it's interesting whether the patient can live well, risk less, with a 2 degree of tricuspid severity, tricuspid regurgitation severity. What if?
I mean, I think you're the expert in this domain more than me, but then maybe Stefan can also comment on this. I personally believe if you cannot achieve a repair, which has a safety profile superior to what we have here and 0 risk of pacemaker, the promise of replacement should be this no tricuspid regurgitation. What is striking in some patients that we have been following is that when you eliminate the tricuspid regurg, the day after the procedure, and sometimes in the afternoon, they tell you, I feel much better. I breathe much better.
I think we also have questions from the audience, and just to be interactive, I would just enter them. There are 3 questions. One was already answered. You mentioned the randomized trial. What's the comparator? It will be most likely the CE and FDA-approved Evoque valve by Edwards Life Sciences. On the other hand, the question that was already raised by Marco was raised again from the audience. Could you please comment on the approximate 8 to 10% with 2+ or TR in this trial? Of course, we have to see that the anatomies are much, much larger. So, of course, if you only offer smaller sizes, you have earlier disease progression than if you offer 7-centimeter devices. This is huge. It's unmet with any other device. So we have to put this in context, perhaps, Thomas. And the last one is, transjugular is related to higher exposure to radiation. Why not femoral access? If you could just shortly comment on this.
I mean, why not femoral access? I would say, why not jugular access? This is first. The radiation is increasing with the jugular access because our hybrid rooms or cath labs are not designed to do jugular access. We do a lot of carotid access, and we have configured our cath lab and our rooms to protect us from radiation. So this is an effort that should be done for us by hospitals and industry in order to protect us. This is better. If they can protect us for the groin, they can protect us also for the neck, I would say. The other thing is, the other question is what? Yeah, so radiation for me is, I would say, a technical problem which is not related to the device itself. The 8 to 10%. So the majority of these patients, if not all of them, were large anatomy, 65 to 70. The angle between the superior vena cava and the annulus was also super wide, so they were at the limit of the implantation. And third, it was the expertise we have been developing with the new device, new features. But I mean, I could witness, and you could witness, and those who use this valve, Julian, also, that after 2-3 implants, you feel very comfortable implanting it, and you can rotate it, you can recapture it, position it, which helps you getting better and better. And also, I would say many of us would get satisfaction having TR2 and say, okay, we can stop here. This was in the beginning, we don't tolerate it anymore. So if you put all this together, you have 10%.
Perfect, Thomas. Thank you very much. We're exactly in time. Thanks a lot. A very large study. And we would now move on to Jörg Kellermeier and put him on stage with